Well, good evening again. I'm Brian Ross, one of the co-hosts. I'm an anesthesiologist here, and so I won't spend too much time in front of you in fear of putting you to sleep, because that's what I do the best. I use the Michael Jackson drug and have much more success than he did with it. Each of the co-hosts get to pick at least one presenter for this mini medical series, and I chose Tom Lenvay. And it's a pleasure for me to introduce Tom. He's a young, energetic, innovative young man, a faculty person in the Department of Urology at Seattle Children's. And I am a bit nervous at my age being surrounded by urologists tonight. I'm just telling you that. I'm standing back and keeping them in front of me. Okay, anyway, Tom came to us by way of Rice University in Houston, where he undergraduate majors in biology and German. We've spent a lot of time together. We tell stories about each other. His mother speaks to Tom in German all the time, and Tom speaks to her in English because he said he's lazy. That's probably true. Tom then went to Philadelphia to Temple for medical school, and then to Atlanta at Emory for his urology residency, and then came to Seattle Children's, to do a fellowship in pediatric urology. Tom is joined in Seattle, as many of us are, our support systems, by his wife, Kathleen, and he has two children, Luke, who is 3, and Will, who is 2, and so I bet you Tom has his hands full right now. His passion and love recently has been to help the University of Washington, the Institute for Simulation and Interprofessional Studies, ISIS, develop a nationally and internationally known program in robotics and robotic surgery. Why robotics? He's going to tell us why. And there's some data with using laparoscopic surgeries, 2 holes in a camera, that warm up. If a physician or surgeon is off for a vacation, or before he comes in to do surgery, if they warm up, their performance and outcomes are better. And Tom's going to talk a little bit about warm-up using the robot. And so I think Tom has some very fascinating work. I think you will be informed, you will be entertained, and impressed by what he's doing. Tom Lenvay.
Thank you. Well, it is an honor to be here. Thank you very much. It was especially to start off this mini med school session. I hope I broke the ice a little bit so you saw the technology out front with the robot. And I'm going to talk to you about how the challenge that we have educating new surgical trainees now. And it ties in very well with the Millennial Generation talk, because education for 100 years has been one way. And that is getting turned upside down because we are having difficulty relating to how people learn nowadays. And it's pretty important in surgery to figure this out fast. So we'll talk a little bit about medical errors, some of the training methodologies currently, and then where we're headed. Well, why do we care about how we train surgery? Well, the wake-up call was when this document was printed, which is The Error is Human. It was a Institute of Medicine finding that almost 100,000 people a year die from medical errors in the United States. That's pretty staggering if you think that the annual car fatalities is 31,000. And it's very costly, these medical errors. So if you look at actuarial data, the most frequent medical errors, of the top 8, 4 of them are related to surgery. And the Joint Commission is the agency that oversees medical institutions in the United States, and they they expect you to report what are called sentinel events. These are a list of sentinel events. And again, as you can see in the top three, two of them are surgery related. So this is a big problem. And well, what's going on in training? How does an average resident train in surgery? The average residency for general surgery is 5 years. There are 5- and 6-year programs in urology, and gynecology is 4 years. And if you took, in that 5-year period, the number of hours, you could see is over 43,000 hours. If you give 3 weeks of vacation a year to the resident, which is generous, then they get 41,000 hours that they could work if they didn't sleep at all. And before the Accreditation Council for Graduate Medical Education changed how many hours residents can work in a given week, it sounds crazy. The work hour restrictions are 80 hours a week. That's the maximum that medical residents can work in a week, and that's an average over 4 weeks. Well, when I was, the classic line that the millennials who are now be joining medical training hate to hear is when their seniors say, well, when I was a resident. And it is true. I'm not in the millennial generation. I'm in that kind of dark, small minority generation. And I was not involved in the ACGME mandate hour working restrictions. And so I worked 100 to 120 hours a week. Now, there were some high-profile cases that occurred in the late 80s and early 90s that drew attention to this degree of work. And some of them led to fatalities, injuries, and that's when the work hour restrictions were imposed. So there's probably an upside to limiting the amount of hours people work. We know that fatigue definitely clouds judgment. And you don't want the least experienced people who are actually in the hospital the longest being totally sleep deprived. We just had a talk recently about sleep deprivation from a sleep specialist, and apparently in patients who are people who are sleep deprived, when they do driving simulation tests, they are indiscernible from drunk drivers. And it turns out that next to high school students and college students, from a risk perspective from a car insurance carrier as far as how many accidents occur, physicians have the second highest number of accidents. Well, after the ACGME mandate, you can see that the hours drop off for the number of hours that a resident can be in-house. And if you actually total that, that's almost a year's worth of hours that they no longer can be in the hospital. And there are upsides, like we talked about, sleep deprivation, but the downside is that we train by experience, and that's how we learn. So if you're not in-house, you're not learning. So the question is, well, do you want your surgeon to be missing almost a year's worth of training? And there's Malcolm Gladwell talked in one of his chapters about the 10,000 hour rule. And this was pretty important. There are certainly a lot of professions that revolve around this. And well, 19,000 hours, that's almost double 10,000 hours. So we should be well trained. The problem is that I can tell you that in a given day's worth of work, at least 30 to 40% of that work that the resident does is not actually stimulating, it's not learning. There's a lot of service involved, and so this is a problem. We're getting close to where somebody's competence can be optimized. Well, we're not able to keep the residents in-house as long, so we need to develop new training methodologies, okay? Well, we also are adding to the mix these new technologies. You saw the surgical robot out there. Well, basically, you can imagine that every year there's new medical devices that come out that have to be learned. And instead of the standard open surgery with the same instruments we've been using for 100 years, now a resident has to learn a new instrument every year. So now you remember that Obama sat down at this console, and then it made it on USA Today and high-profile magazines that he talked about robotic surgery as in part the innovation of the healthcare plan, and that may be true. This is probably the Model T Ford iteration. No offense to the company that makes it, because it's a pretty impressive instrument. But you're looking at literally the first iteration of a clinically used surgical robot. Well, this is how fast hospitals have adopted robotics in the United States by year. Partly driven by physicians, definitely driven by public interest and marketing. And so we have to figure out if this is actually better for patients. There were high-profile cases this past year that drew questions to whether robotics actually does better. So this is the number of cases that have gone up worldwide with robotic surgery by year. And that number of systems installed is actually now 2,000 worldwide. And if you look at prostatectomy surgery, that's the removal of the prostate for prostate cancer, you can see that's a big jump. Well, gynecologists, now that they have approval to use the robot for removal of the uterus, you can see that slope is even higher. Right now, we train by opportunity. If a patient walks into the hospital with a certain type of lung disease and residents on call and they admit the patient, then they just learned about that disease. And that'll help them when they're out practicing. But there's a lot of variability. You go to a high volume center, you're going to see more. And you are going to have different outcomes based on what types of patients you got to see. So that's probably not an ideal way to train, but it's the way we've been training for 100 years. But when I was a resident, I worked at a hospital, one of the hospitals I worked at, which shall go unnamed. I learned how to do a laparoscopic nephrectomy as part of my training, and that's the removal of a kidney for a kidney cancer. And when I was at the chief resident level, that's the last year in residency, I worked at a hospital where the chief resident was the attending, basically. There was an attending that oversaw your patient charts, but I did my first laparoscopic nephrectomy with a junior resident with no attending oversight in the hospital. And I could tell you that I was at the tail end of that type of experience in training. Dr. Joyner was in a training area where that was how you learn, discovery learning, which is very powerful. If you make a mistake by yourself, that you will never forget that. And it's different if you have somebody standing next to you and you make a mistake and they give you feedback right away. It won't really resonate as powerfully, but it is not the way, it is not safe to do it that way. Fortunately, we don't have that system anymore. We have, the autonomy is a lot less. But again, we have to make up that gap. What you learned with all that autonomy and discovery learning, now we have to somehow instill confidence. If you look across the country, residents who are graduating are choosing to do fellowships, surgical fellowships, which means additional training. And one of the thoughts is that they don't feel confident coming out of residencies to be on their own. And if you look at private practices that are hiring residents right out of training, the senior partners won't be letting the junior partners operate alone for a period of time. So there's a continuation of education that goes on. Well, we have to change that paradigm of teaching. We need to train to proficiency. That would seem logical. We need to have cognitive competence benchmarks. So it's not only how good you are technically. There is obviously a wide variation of technical skills, and we can train to independent needs. But you have medical decision-making, surgical judgment, makes up the majority of a good surgeon's practice. And I can tell you that is not easy to train. If you walk into a patient's room, a good surgeon can tell literally within a few seconds that this patient is sick or not sick. It's called the eyeball test. How does the person eyeball? And we don't know how to train that. Some people get it and some people don't. And this is going to be the major gap that we need to fill. We need to be, just like you go to a driver's ed class and you go to driver's, and then you have to take your driver's test. That's a technical skills certification test. Well, we don't have anything like that. If you can imagine, there's nobody that actually is making us take a standardized technical performance test to go out and be able to do surgery. You go through residency, and I can assure you that most residencies, the people overseeing the residents know when somebody can graduate or not. However, there is really no standardization for that training. So what will be coming down the road is every 10 years, you're probably going to have to do some type of technical skill. At best, right now, you submit your operative logs and your complications to an oversight committee. But you can imagine it's really important, especially with this new technology that comes out. You're not just operating with your hands, you're interfacing with electronics. You're getting a lot more information brought back to you. And when new technology comes out, we need to compare it to the gold standards. So what's called comparative effectiveness. And actually there was a major push by the NIH to study different treatment plans for surgical patients. And we need to do more for the Da Vinci robot and for other types of training. The aviation industry, they keyed on this very rapidly 30 years ago. And we're just now getting into the game. So that leads me into simulation training. And so simulation training, if you imagine, is basically a mock surgery, mock medical decision making. And the nice thing about simulation training is that you don't need a human patient to practice on. You can focus on the person actually learning the skill, and it's safe for them to make mistakes. This is a big thing because we want to teach errors. If a trainee gets a complication or gets into an artery they're not supposed to during surgery, they'll get pummeled. So, I mean, they'll feel bad and they will be made to feel bad. And we want them to learn, okay, you got into the artery, now what? And actually, it's really hard to teach the right thing when they're really worried about having done the wrong thing. In this environment, we actually pick errors that we want them to make. Just like a flight simulator, they get to demo all different types of flight scenarios, and they're supposed to make mistakes, and then they get feedback, and they learn from their mistakes. You get to do it multiple times, and the feedback is very immediate. You don't really know in a patient that you necessarily did anything wrong until you have the complication, which can occur downstream, days, months. So this way you know right away. And if you are going to train by opportunity, you're going to miss 80% of some type of medical disease presentation. There are apparently more than 10 different ways that the gallbladder vessels the blood supply of the gallbladder can look like. And if you are at a training program and only saw 2 of them, you could get into trouble when you get out there on your own. Now you can actually have somebody go through all 10 different ways of seeing the anatomy. And you can base your ability to advance on how well they're performing. There is actually no way to do that right now. The way somebody's trained in the operating room is you go in with the surgeon and you get to do some of the case, depending on the confidence level of the surgeon in the trainee. But it's all subjective. Somebody may actually let you do more than somebody else, but you may not be ready to do more. And there's no standardization right now. That's a problem. And you can give the feedback objectively. There are a lot of politics in medical training. And some people are liked and some people are not liked. So you have no idea whether the feedback you're getting is sincere. We need to understand who our residents are. So as Dr. Joyner was talking about, there's the literal learning and there's visual, and people learn differently. And the current generation coming in through medical school learns a lot more visually than just seeing a bunch of words. And apparently video gaming plays a big role in being able to discern technical skills. So it turns out that there have been some pretty crafty studies with laparoscopic surgery, the keyhole surgery, that if the subjects are actively doing video games throughout the week, in their residency, they actually make fewer errors when learning laparoscopy. And that also crosses over to music. So if you are actively playing an instrument, you're practicing when you're at home, you perform better laparoscopically. And so we need to kind of exploit those things. And some have even said that we should select people who are technically savvy already in med school. So basically seeing who can cut it technically in their first and second years, and then deciding which track they should go on. Now you're not going to be doing surgery because we don't want you in the operating room. So, and so there's clearly an ethical discussion that needs to be had. If I were a patient, I would want the person who's going to operate on me to be the most competent person, technically great, and have a good bedside manner. The simulation curricula that we create now to test cognitive, this is an example of a web-based training module for a new trainee who's learning to do gallbladder surgery. And since trainees nowadays learn visually so well, this is basically what happens is a video will play through a gallbladder surgery, and then it'll stop. And the trainee then is kind of confronted with, okay, what's the next step? What's the next instrument you go for? And this can be objectively measured. It's interactive. And again, no patient you're not practicing on humans. And then there's reality-based, so skills performance. You want your surgeon to be practicing suturing. You want them to do a gazillion knot ties to become proficient. And I can tell you people are very different in how they learn basic technical skills training. And then there's virtual reality. Some of you may have seen what was going on during the break. This is a virtual reality simulator for the robot to teach robotic skills. And the nice thing about virtual reality is that everything that you want to study about somebody's performance, their task time, their what's called economy of motion, which is a surrogate for experience level. So how far the instruments travel over time. Because somebody who's all over the road and learning a task will have much worse economy of motion times than somebody who does this all the time. You can change, it's computer driven, so you can change up the scenarios very easily. Well, virtual reality, computer games, does that really actually improve anybody in the operating room? Well, it does. There have been studies to show that if you do training in a virtual reality environment, that you perform better. So this study was on surgical residents doing the laparoscopic removal of the gallbladder. And if they were trained in the standard fashion, they ended up performing the surgery in a longer period of time, and they had a lot more errors. So we know it works. And as Dr. Ross was talking about warm-up, this is something that I'm really interested in because all these other high-stakes professions use warm-up, but we don't. You can imagine that, and these are, of course, these are demonstrations of psychomotor warming up. You go through the motions, just like a tennis player goes through the motions. But there's more to it, and there's actually data that show that if you stimulate memory centers in somebody's brain while they're also going through these psychomotor motions, that they're primed, they're ready, they have what's called their activity set. So they are ready for whatever task is about to come. So I want to see, and there are others exploring this, if you can prime a surgeon right before their surgery, and I do this in the operating room with the residents. If a resident is going to be doing some laparoscopic suturing, which is very hard to do, I have them step out of the case, go over to the box trainer, have them do some suturing, and then I have them come scrub back in. And they say they're primed. This hasn't been done in a prospective manner, but right now, but it's going to be. And this is, you know it, I know it, and it turns out that when they take experienced surgeons and try to prime them, they perform better. So it doesn't matter if you're a junior resident. Even if you are an expert surgeon, you benefit from priming. And about the fatigue, it turns out that priming can bring a fatigued person back to their baseline performance level. So maybe we should be priming people who we know are on these long shifts. The other important thing, the military is interested in this because, as you can imagine, that their soldiers or their surgeons get deployed and come back, and they are expected to go back into their regular practices, and they need to remember all their skills that they were doing. So to see if warm-up actually works in the operating room, this is a study that was done using this simulation module here. They wheeled the simulator into the operating room, and right before the resident was going to do the laparoscopic procedure, they got to do this. And again, they saw fewer errors and better outcomes in the patients. It seems like a no-brainer. Yes, you should be warming up. What do surgeons do before they operate? They're managing patients on the floor, reading the newspaper, eating the rare time you get to eat when you're operating. And we should be probably focusing on the actual suturing tasks, et cetera. So what I'm looking at is actually taking this and using this to prime people to do those robotic tasks out there. And we actually get to do this through the Department of Defense. They funded us to study this with Madigan Army Medical Center. And it would be really cool if we could show that doing 5 to 10 minutes on this will make you a better surgeon in the operating room. But this is expensive. This is $100,000. So what if we could take a Wii station or PlayStation and pick the right tasks, like Sonic Hedgehog, and use that for 5 to 10 minutes right before we go in and operate? If we stimulated the right centers in our brain, that you can imagine having Wii station outside of every operating room and make it required that the surgeon warmed up or the resident warmed up before they came in. The other thing we want to study is how can we accelerate learning curves? Well, that's a pretty tough thing to do. I have a little demo here that I want you guys to partake in. This is a video of 2 different surgeons, an experienced one and a novice. And I want you guys to raise your hand as soon as you can tell me which one's the expert and which one's the novice. Okay. Right. So that took all of 4 seconds, right? The processing that your brain did for that, that's really hard to train, to teach somebody that. Well, what we want to do is develop software that can do what you did in 4 seconds and do it on the fly. So when I'm sitting in the robot console doing surgery and doing some type of surgery where I'm doing suturing or something highly technical, I would see a little number in the right-hand corner from 0 to 100 that's flexing based on whether my motions and how I'm handling tissue is more like the experienced people or more like the hacks. So, and this would be real feedback, like you're getting warmer, you're getting colder. And that requires getting a lot of experienced people's data, but the computing technology exists to do this already. And using machine learning algorithms, we can figure this out. And this would be really something, because then you talk about those 1 year of training that we just lost because residents can't be in the operating room. Well, we just gained it back because we can cut down their learning curves by 75% of the time. Well, the other thing we have to do is, well, this is great. We get to pick up blocks and move things around in space, and we can learn how to use the robot, and we learn how to use laparoscopy. But what really would be cool is taking an X-ray or a CAT scan of somebody that you're about to operate on and turn it into 3D models or a virtual reality model and actually do the surgery before you do the surgery. And that's where we're headed. The problem is the tissue modeling. So this is from the University of Minnesota. Rob Sweet is the lead investigator. And basically, he's created software that can do just that. Take imaging, turn it into these 3D models, and then, this is the bladder, what you see in front of you, and then figure out, well, what would the bladder do if I pushed on it with my instrument? Because tissue modeling is very difficult. That's kind of one of the gaps we have in surgery, is we can't figure out what tissues will do when you push on them in a virtual reality world. But we're close, and you can imagine that your surgeon would probably be better off having practiced on a computer image of you before going in. So this is just another example of what we can do already, which is simulate how we can set the robot up in relation to each patient. You take the imaging and figure out where to put those robotic instruments. And you can do it all the way down to the babies. So the other step is, how do we provide patients the best care when the expert's not around? So, because the person who's best at doing some kind of coronary artery surgery may be 3 states away. And so we want to figure out how, when I was down there, I was talking about, we use that console in the same room as the patient. But you can imagine that we can do this just through regular internet connections in a remote fashion. Then you can provide expert care no matter where they are. You have limitations. There's obviously video transfer, there's delay. So you have to teach surgeons how to operate in an environment with delay. And surgeons are not patient. So this is hard. I don't know if you all know, but when you go to our professional society meetings, there are live surgeries that go on. So when you go by the Intuitive, which is the company that makes the Da Vinci, you go by their booth see their robots. There is a surgeon somewhere in the country that's doing a surgery on a patient that's being televised to this trade show, live. So that clearly, there's probably some ethical considerations, because you can imagine that surgeon may not be operating in the exact same frame of mind as the surgeon that is just taking care of their patients without public display. But it is a good way to see how people operate. So we have to figure out how to kind of change from live surgery to something just as good. Well, you can also proctor. I was talking about when you come out of training for robotics, you've done a few proctored cases, but the person's sitting in the room. What if you have the proctor on the laptop 5 states away giving you guidance while you're doing surgery? The problem is that you can't do telemedicine right now across state lines. It's illegal. So you couldn't operate on somebody in the United States across state lines. In fact, in Texas, if you do some type of telemedicine, you get fined $4,000, and the next time you go to jail. But there are states like Virginia that just passed legislation this year where they're actually going to reimburse telemedicine through their Medicare and Medicaid strategies. And how do you compensate the surgeon? How are they going to bill? They weren't there. So how do you figure that out? And then the security. We already know that there are terrorists in the Middle East who can hack into the signals coming off of the drones, the U.S. drones that fly around, with the $26 software called Spy Grabber. And so you can imagine this would be a problem. I was doing robotics and somebody hacked into the signal and then changed the signal. So that gets back to the surgical signature. If the device knew that I was operating and something deviated from how I normally do something, it would trigger some type of, it would ask me, is this right? Did you really just do this? And this is, like I was talking out there, this is the Model T Ford of robotics. And it's huge, as you can see. That thing takes up all the real estate over top of the patient. It's cumbersome to move around. It's very delicate and precise when you're operating. But there are many different robots coming down the pike, including there's a surgical robot that was designed here at the University of Washington, funded by the Department of Defense, that weighs 80 pounds, that weighs 1,200 pounds. And we have to figure out how all these different devices can talk to each other and how we can control all these different devices. So there was actually an experiment done where multiple robots around the country in labs, this was not on patients, in engineering labs, were controlled simultaneously with all different types of interfaces. And this was a proof of principle that you can govern robots transoceanically, and it doesn't have to be the same type of robot that you have. That's what's coming down the pike. And what if you want to have multiple surgeons working together, but they're not in the same state, or they're not in the same area? This was a really neat demonstration where 4 surgical robotic arms were controlled by 2 surgeons. This is Dr. Mika Sininen, who's a professor here at the University of Washington. And we were controlling this robot from Seattle from 2 separate rooms down to UC Santa Cruz. So this is going to happen because we're going to want the experts operating in the abdomen or in the chest, and they're going to have to communicate. And we have to figure out what the best way, how can surgeons collaborate when they're not right across the operating table from each other? These robots are now being deployed to those 7 institutions that you see in the little inset. So we're right around the corner from having these institutions doing collaborative surgery with each other and studying how we can educate in that field. And then I'm going to close with this video because this looks way futuristic, but this actually is not in practice on patients yet, but it is probably about 2 years away. And this is a totally different way that surgeons are going to be operating, where we can govern multiple robots or multiple platforms from one station. So, and you can see that there's a lot of use of, and now with the Microsoft Kinect, by the way, you want to talk about a disruptive technology, that we're going to be controlling robotic instrumentations with hand gestures. So, and we're going to be scrolling through the x-rays of the patient just by doing this to expand and sweeping down our hands in the middle of the operating room. And the Kinect is $150. That's going to be a game changer. But again, how are we going to make sure that we train people appropriately with this technology? Because the amount of technology that's been introduced in the last 25 years just completely flattens everything that happened before that, the 100 years before that. And yet residency is still 5 years. And it was 5 years 40 years ago. So we have to figure out a better way. So this is where we were. This is how we learned. You sat around a big amphitheater. You watched somebody operate. You watched, obviously, the most senior person. This is the Thomas Eakins, actually the first one was the Thomas Eakins painting. And this is where we're headed. This is a completely automated operating room. Totally robotic. The scrub tech, circulating nurse, the robot, and there's the surgeon sitting, controlling everything all by himself. And in that little circle, that's the patient. That's what we can't lose sight of with all this technology. So that's it. Thanks. No, it's okay.
I'm going to have Tom stay up and Byron come up. We're going to take questions from the audience. You'll need to go to the microphones if you have questions. Pardon me? Oh, okay. Well, Byron will have to he'll use the hand. And so we'll take questions. This is incredible, what Lenvay is doing here and where they're going with surgery. I just find it completely fascinating. I did want to make a point. I think there is an anesthesiologist there someplace.
No, there's not.
No, but this year there was an automated anesthesiologist.
An avatar anesthesiologist. So anyway, But and am I just come? Why would you want a totally this kind of an automated surgical theater? Well, as people come into a surgical theater, even as clean as we are, we introduce infections. And if you have a prosthetic hip or prosthetic knee and an infection gets in that, it is a mess for years to get that cleaned up. And so in a couple years, we will have a totally sterile environment for prostheses being put in that should help decrease the complications. So there are reasons for doing this. Question over there.
Now, the surgery is going to be operated by robots. How do you think the role of physician would change?
Okay. So how is the role of the physician going to change as the robots come into our lives?
Yeah. So that's a great question. Do you remember when I was talking about medical decision making? Since that's still really the majority of surgery, yes, you can have automated robotics doing the surgery, but you have to decide. It's really hard to decide whom to operate on. And then while you're operating, how to get out of jams. And so I don't think that the role of the surgeon will completely go away. The surgeon will instruct these technologies to perform the surgeries, but we have to be there to make sure that we're doing the right thing at the right time, and we're picking the correct patients on which to operate.
Can you imagine at some point with robotics that you scan a patient, say for brain surgery, they do a 3D reconstruction, the surgeon sits down at the console, makes a couple different entries deciding which is the best way to approach this tumor with the least injury. They do this, and while they're doing it, they record it on a hard drive, and then they take it into the OR, plug it in, and it's done, just like that. And they don't really do the operation, but it's recorded.
Right.
I think that could be coming a few years from now.
Yeah.
I would agree with Dr. Lenvay that the toughest thing that we do is teaching judgment in medical education. You can walk into one patient's room who's a 2-year-old, walk into the next room, you have a 20-year-old, walk into the next room, you have a 42-year-old, and they all have very different problems. And you have an idea of what they have, but typically they have multiple problems. And one of the things that I think we need to do is be better at communicating with our patients and involving them in their care. And that's something that our robot, I don't know, is ever going to be able to do.
Another question or not? Yeah, go ahead.
Are we going to see the role of surgeon outsourced to China, India, Vietnam?
Yeah. Oh, don't you love this? That's
Well, as it turns out, there are actually plans within the next year to try to do a surgery from Brazil to India. And you can imagine that if the surgical expertise is somewhere else, and you, as a patient, again, I want to be operated on by the person who has the best track record in that type of procedure, disease, etc. So it turns out that actually people still come to the United States for their medical training. So we do still have that market cornered for now.
So this could be a general advertisement. I think if we don't do something about math and sciences and whatever in elementary, high school, and college, we're at risk of losing a lot of different things to countries. So. Yes, can you come up to the mic?
This is a simplistic question, but how do you mitigate complications during the procedure? If the machine breaks down or the person has a heart attack, and you've got all this stuff on top of them, and you're doing it remotely.
So actually, I can speak to that firsthand because there was a program, I think it was King 5 or one of the local news agencies was doing an expose on surgery at Children's, and it was 24 hours in the day of the operating room, and they had actually picked a few surgeries to highlight, one of which was one of my robotic surgeries. And really probably within the first hour of the case, we had a mechanical failure. This was, if it had to be on primetime news, right? And I had to basically disengage the robot, and fortunately I was trained to do the surgery through the pure laparoscopic approach, so manual control of those same types of instruments you see out there. And I basically went ahead and performed it that way. So, but I can tell you that most robotic surgeons out there in practice do not have good laparoscopic training, and they're going right into robotic surgery. And Dr. Joyner in particular keeps this in mind because he has colleagues like me who are, my niche is the minimally invasive surgery, the robotics and laparoscopy. But if something happens, you have to turn that surgery into an open surgery. And trainees are not getting enough experience through the standard surgical way anymore. So that's actually a real concern.
This is a real concern for the Accreditation Council for Graduate Medical Education, who thinks that surgeons aren't getting enough time in the operating room and certainly aren't using that time to learn about open surgery should you need it. All robotic and laparoscopic and minimally invasive surgeries can be changed into open surgeries if there are problems. And we need to train residents on not only the real anatomy and the open surgeries, but all these other technologies. So surgery is getting a lot more complicated than it was when I was going through 20-something years ago. And we still have to be proficient, efficient, and I think competent at training, and also on the other side at learning. So there's a lot more going on in medicine and in surgery these days than was when I was going through.
Over there, question? And then-
Aside from the lowered risk of infection, what is the advantage to someone who needs just a simple prostatectomy or hysterectomy? What is the advantage to him or her of having a robotic surgery and not having it the old-fashioned way, so to speak?
I'm going to interrupt just one second. At being at my age, simple prostatectomy isn't words that aren't the kind of words I use, but maybe they come to some people's mind. But go ahead and answer the question.
Yeah, so that's a really good question. So it's really interesting because minimally invasive surgery has shown that you can, especially in adults, that you can get patients out of the hospital sooner. They can get back to their jobs and their lives sooner. They may have less pain after surgery. These are all the benefits. And what's really interesting is there was a group in Vanderbilt that actually studied prostatectomies, and they had developed a care pathway. So after robotic surgery, they got this medicine, they were out the door, and the 24-hour period, and the majority of patients left. When they applied that care pathway to the open surgery, where the patients used to stay 3 days in the hospital, they actually could get those patients out the door the same way within 24 hours. So what we have done is we've definitely pushed open surgeons to really see what are we doing that's dogmatic, just keeping a patient in-house, watching them longer, what is unnecessary. So we've actually driven open surgery to improve.
I think that's one of the things that is so incredibly fascinating about medicine is that we're constantly learning, relearning new ways, and improving the quality and care of our patients. And we kind of compete with each other to do so. One of the things that I have to say about Dr. Lenvay, and he actually was a fellow of mine, is that he's very fair about how he presents data. And as he just gave you that information about open and robotic surgery, he's a minimally invasive surgeon. I only do open surgery. But I think he still says in many areas that the gold standard is open surgery. This is still new practice, and it's wonderful, and it's going to go way far further than we really even think it's going to go. But I think that Dr. Lenvay, with his unbiased thoughts, keeps things real for everybody.
So we'll take one more question, and I'm going to be telling the millennials that we're taking one more question and then ending. Okay, so we'll have one and then, okay. Yes. Right.
This is a little bit of an extenuation of the question that was just previously asked. In an open surgery, say for example, with adenocarcinoma of the uterus, open surgery that takes about an hour and a half versus a robotic surgery that's about 4 hours, is there a disadvantage to the patient from that standpoint versus the quick recovery?
Yes, there's definitely a disadvantage to being under anesthesia for longer periods of time. But the problem is that you may be comparing the surgeon at the beginning of their training or at the beginning of their learning curve. And one would hope that the point of adding this technology will get the times down below the open surgery times and the pain after surgery below those open surgery results. And that goes back to the comparative effectiveness research that is lacking, frankly. We don't have enough of that because everybody is so excited about introducing all this new technology and using it before we even know if it's better or not. And I can tell you from a hospital perspective, they see this as a marketing tool to some degree because people see they're on the cutting edge of technology at this institution. Therefore, we must go there for our care. And so, but it's completely outpaced data. So it's a very good question, and we need to look critically. And I will tell you, in my experience, my early robotic surgeries took longer than if I did them in an open fashion.
Let's thank Dr. Joyner and one more time.